Hello and welcome back. I'll be discussing an approach to vomiting and or abdominal pain, and this will be part 2.5 in this series. We'll be discussing focal or localized pain that can be localized to the spleen or to the liver or to the kidney due to distension of these parenchymal organs. So I'll start off per protocol with a case. So this is a 46-year-old gentleman with no known prior comorbidities, no history of substance use or abuse, who is now presented with abdominal pain for the last 2 to 3 weeks, with gradual onset of persistent, non-progressive, deep-seated, left upper quadrant, dull aching or catching type of abdominal pain, which is moderately severe and radiating to the left shoulder. And this pain was associated with a sudden worsening of the pain 2 days ago, and there was this worsening was associated with an increase in pain while taking a deep breath. So there's no history suggestive of alteration in color of urine or passage of stones or pus in urine, and there's no decreased urine output. There's no history suggestive of altered bowel habits, vomiting or hematemesis. There's no significant drug history, and on examination, the general examination is normal. The vitals are normal. There is some left upper quadrant tenderness with some mild splenomegaly. However, there's no guarding and there's no shifting dullness. Now, there are no available investigations as of now. The patient has just come to you in the OPD or in IPD. And so based on the framework that I've put forward, what are the possible differential diagnosis? So obviously this patient has a significant localized abdominal pain and there's no history of vomiting, so it's without vomiting. So in such cases, as I've discussed, the possibilities include peritoneal inflammation or peritonitis, distension of hollow viscus, acute mesenteric ischemia, hollow viscus implying the GI tract, then by distension of parenchymal organs and acute pancreatitis. Now, of this, naturally, this is not a hollow viscous distension because there are no altered bowel habits. So you can see it there here. So you can remove that. Then, because the history is not suggestive of any alterations in bowel habits, no preceding, increase in bowel motility followed by progressive decrease. So it's not acute mesenteric ischemia. And naturally, the localization of the pain and the type of pain does not uh, indicate acute pancreatitis. So these three entities can actually be removed from the differentials. Now, after that, if we have peritonitis and we have parenchymal organ distension, of that peritonitis is very unlikely because of the lack of fever, the lack of systemic features, and most importantly, the lack of guarding on examination of the abdomen. So that's a distant second in the differential diagnosis. So you're essentially left with pain due to parenchymal organ distension. And considering the location of the pain and the type of pain, naturally it is either the spleen or the left kidney. So you're left with the spleen and the left kidney, and because there is no alteration in color of urine, no passage of stones, no passage of no decrease in the urine output, again there is nothing to suggest the kidney. And again the pain is worsening with taking it when the patient takes a deep breath, indicating that there is some structure that is mobile within the abdomen with respiration, that is an intraperitoneal structure is involved, again indicating that it's likely the spleen. Okay, so as we've discussed in this diagnostic table, this is probably then therefore a splenic pathology, and among splenic pathologies, it is likely either splenic inflammation or splenic infarction. Okay. Now, there is a small possibility of renal infarction as well, especially if it's unilateral, because if it's unilateral, you may not have a decrease in urine output. But usually, renal infarction is not painful unless it's renal venous outflow obstruction, and in that case, there is flank pain and often gross hematuria, some at least microscopic hematuria. So it's possible, but it's unlikely in this particular case as of now. Okay. So now, clearly, it's a diffuse splenic pathology more than a splenic infarct. Okay. Now, why did I say diffuse splenic pathology? Because there's some degree of spleen enlargement on examination. And why not a splenic infarct? Because of epidemiology, most of all. Because splenic infarcts, as we'll see, most commonly occur with infective endocarditis and vasculitis, and the patient has no other clinical manifestations suggestive of the same. But again, I'll like to elucidate this a little bit more as we go into the discussion. Now, uh, an important question that does arise is why is there a sudden worsening of the pain of the patient? So over the last 2 days, there is a significant worsening of pain, and that's a little odd. It's it's something you might ignore in history per se if you're not careful, but it is, it's, as we'll see, rather significant. Okay, so that brings us to the discussion proper. This is part 2.5 in an approach to vomiting and abdominal pain. So in this screencast, I'll be talking about, I'll try to enumerate the causes of abdominal pain due to splenic enlargement. Specifically, we'll talk about diffuse splenic inflammation versus infiltration, and the radiologists use a term called non-traumatic splenic rupture. Okay, and we'll try to you know get used to the possible differential diagnosis that lends itself to this kind of an imaging finding, so that in the next discussion when we talk about imaging for in the diagnosis of such presentations, uh, the this term makes sense. Okay. Then we'll try to enumerate the causes of diffuse renal inflammation, of which I've already discussed interstitial nephritis. Uh, and then I'll talk about pyelonephritis with or without a renal abscess formation. Now, of this, I'll go into the details of pyelonephritis and try to describe it as a form of urinary tract infection. I'll try to differentiate it from any symptomatic bacteriuria, that is UTI from asymptomatic bacteriuria. Describe the spectrum of clinical entities that constitute a urinary tract infection. Understand the pathomechanisms that lead to the development of a urinary tract infection. We'll describe the resultant epidemiology of UTI that results from the pathomechanism and the further risk factors that arise. And we'll touch upon the treatment protocols of UTI, primarily because often that is a diagnostic clue. Okay, so response to treatment becomes this thing. Okay, and we'll talk about treatment protocols in special clinical situations because again, this is something that lends itself to the clinically as a diagnostic clue. Okay. Now, finally, we'll try to enumerate the causes of renal and splenic infarction. And I'll explain to you why thrombosis, embolism, and vasculitis can result in this kind of a presentation. Okay, so now coming to evaluation of diffuse splenic inflammation. So in this case, we by definition exclude splenic infarction and splenic vein thrombosis. Splenic vein thrombosis I have already discussed in the previous screencast. In terms of its etiology being similar to the etiology of hepatic venous outflow obstruction, that is Budd-Chiari syndrome. Uh, Splenic infarction we'll be discussing in relation to in comparison to renal infarction at the end. Okay, so we've in a previous discussion already analyzed the mechanisms that lead to splenic enlargement. This was discussed under an approach to generalized lymphadenopathy and splenomegaly, part 1. If you've not had a look at the video, please, I'd urge you to go and have a look at that there because I've discussed the derivation of the diagnostic framework in detail there. Now, like I said, there uh, you have generalized lymphadenopathy and you have splenomegaly. There are four possible things that can cause generalized lymphadenopathy and or splenomegaly. The first is lymphoid proliferation in response to some thing that activates the immune system. So that naturally will cause generalized lymphadenopathy and it will cause splenomegaly. Now, increased RBC phagocytosis, say in autoimmune hemolytic anemia, will not result in lymphadenopathy, but it will result in splenomegaly because the spleen is a site for erythropoiesis in utero and therefore is able to pick up uh, as a site of erythropoiesis in adults when there is extra, when the production of RBCs within the bone marrow is not adequate. Then we have it's able to, so that's why there is extramedullary hematopoiesis. Sorry, and increase RBC phagocytosis because naturally there are no macrophages within the lymph node that would, enlarge and therefore be involved in removing RBCs in normal circumstances. Obviously, if a person has this thing has got hemophagocytic lymphohistiocytosis, the lymph nodes can be involved. But again, under normal circumstances, lymphadenopathy does not correlate with RBC phagocytosis for reasons that I just explained. Extramedullary hematopoiesis naturally only causes splenomegaly. Now, finally, cellular and non-cellular infiltration can occur in the lymph node and it can occur in the spleen. Not necessarily, not all causes of um, generalized lymphadenopathy due to cellular non-cellular infiltration result are associated with splenomegaly and vice versa, but there is significant overlap. Okay, so now of this, the lymphoid proliferation due to immune activation and cellular non-cellular infiltration are the only two causes that can cause abdominal pain, because in order for pain to arise from the spleen, there has to be one of two things that has to happen. Either you have to have a rapid distension of the renal capsule, so the process has to happen very rapidly, so or very rapid immune proliferation or a very rapid cellular infiltration or into the spleen. Naturally, extramedullary hematopoiesis and RBC phagocytosis are slow processes, so they don't cause very rapid splenic enlargement. The other thing that might happen is direct inflammation of the spleen with involvement of the splenic capsule in the inflammatory process. And naturally, immune activation the initial paths of innate immune activation are what constitutes inflammation. So similarly, depending on the type of cell that is infiltrating, there may be inflammation. Okay, now in that discussion, we had talked about in situ cellular proliferation due to excess immune activation being due to infections. So these were the infections that we had discussed in that headache. So now of these, abdominal pain occurs only in cases where again there is either rapid enlargement of the spleen distending its capsule, or there is direct inflammation of the splenic capsule. So I've highlighted, or I've shaded out the causes that are less likely to cause rapid enlargement, and then we are left with essentially a few differential diagnoses. So these are the differentials that can cause it. Of particular importance are tuberculosis and splenic abscess formation, and four viral infections, that is our CHI, that is cytomegalovirus, hepatitis viruses, AIDS or HIV, and infectious mononucleosis, both typical and atypical forms, and less commonly even other viral infections. But as you can see, it's very unlikely to happen that rapidly. Okay, fine. The brightness in this case represents the clinical likelihood of these entities satisfying the two criteria that would result in clinically significant abdominal pain. Now, cellular or non-cellular infiltration can, again, like I just discussed, cause splenic enlargement. So, of that, we had discussed that these are the possible differentials of lymphadenopathy or splenomegaly. If this doesn't make sense to you, please go to the other discussion, and I've discussed it in detail there. Uh, See, again, splenic enlargement is only going to be painful if there is rapid enlargement or that stretches the capsule, or there is a quote unquote non-traumatic rupture of the spleen. Okay, this rupture could be due to tissue necrosis, that is similar to what might happen in a splenic abscess, or it could happen due to splenic infarction. And as I've discussed, splenic infarction we'll be discussing in comparison to renal infarction because of similar causes. So that brings us to neatly to uh, the diagnostic nodal point, that is called non-traumatic splenic rupture. So, see, a non-traumatic splenic rupture essentially means that an imaging of the abdomen was done, and they found that the integrity of the splenic capsule is not intact on imaging. Okay, so that naturally correlates with the clinical presentation of pain arising from the spleen. But again, all causes of splenomegaly are not likely to cause this kind of non-traumatic splenic rupture. And the emphasis here is on the non-traumatic, okay, because by far the most common cause is traumatic. Now, again, naturally, rupture of the integrity or loss of the continuity of the splenic capsule could be due to necrosis of the underlying splenic parenchyma, or it could be related to bleeding, sudden bleeding into the parenchyma of the spleen, stretching the capsule suddenly. Okay, which could be spontaneous. In this case, naturally, we'll be first concerned with coagulopathies, with any derangement in the coagulation cascade. So I'll be, and I'm not going to discuss coagulopathies here because that'll be a separate discussion under approach to a patient with bleeding diathesis. On the other hand, we have parenchymal necrosis. The parenchymal necrosis, like I said, could be because that area of the spleen has lost its blood supply. That is, there's an infarction of the spleen, or there is inflammation in that area of the spleen. And inflammation naturally, because of neutrophilic infiltrate to a lesser extent macrophages, result in enzymatic and reactive oxygen species mediated degeneration of the tissue in that area. Now, infarction can be in a spleen that is normal in size, and it can be due to a enlarged spleen. Now, when a spleen is grossly enlarged, it is normal for parts of the spleen to outgrow their blood supply because of the anatomy of the blood supply of the spleen in a normal person also. But there is vessel occlusion also is a cause of infarction in a relatively normal size spleen. Now, importantly, as we'll discuss this in more detail later, this almost exclusively is due to vasculitis or vessel damage. It is not due to thrombotic occlusion most of the time. It can be due to cardioembolism. It could be due to vessel inflammation or vessel damage due to some other local pathology. But it is never due to, almost never due to atherosclerosis, because the splenic artery is a muscular artery and it is a very long artery. So usually the pressures in it fall along because of the loss of pressure head. They fall along the splenic artery, and therefore atherosclerosis and involvement in that artery is very rare, or actually technically not possible. Now, note that I have not included vessel thrombosis. Again, this will be discussed in this actually has already been discussed in comparison to previously, and I'll be discussing it in comparison to renal thrombosis. Splenic arterial thrombosis is odd in any situation except for a complication of acute pancreatitis, because as I discussed, the length of the splenic artery is very long. So because of that, we end up having a lot of pressure loss along the splenic artery, and therefore the splenic artery, the flow within the splenic artery is usually not, it's laminar and it's not very high speed flow, so it doesn't cause that much shear stress on the endothelium, and therefore the atherosclerotic plaques within the splenic artery are very odd and usually do not occur. Okay, so that's why, and the other thing is prothrombotic disorder workup in case of splenic artery thrombosis is again usually not indicated, although there are certain situations in which you may consider it. But it's a very unusual location for such a thing to occur, because again in diseases such as antiphospholipid antibody syndrome, the distribution of the thrombosis also reflects the locations in the vasculature where flow is non-laminar. So again, if there is laminar flow in the splenic artery, it is less likely to get involved. Similarly, cardioembolism is technically a possibility, but would rarely, if ever, cause pain or non-traumatic splenic rupture. Okay, so it can obviously in cardioembolic involvement of the spleen. On imaging, you might pick up wedge-shaped infarcts in the periphery of the spleen, but that is not likely to cause pain most of the time. So that is why it's not likely to be included in this category. So this is just an incidental finding of imaging, contrast enhanced imaging. So finally, we'll get into the causes. So I like to divide the causes into these four buckets. Okay, and we'll be talking about the four buckets separately. So first is inflammatory disorders, of which autoimmune disorders are the first things that we'll discuss. So essentially, any autoimmune disorder can cause a significant enlargement of the spleen, and in that case, they can be, the spleen can outstrip its blood supply. In literature, sarcoidosis has been mentioned multiple times, but again, it's not really that common of a thing in sarcoidosis. Then, on the vasculitis side of things, particularly polyarteritis nodosa has a tendency to involve the spleen. Now, also, their non-traumatic splenic rupture has been described with granulomatous polyangiitis and Behçet's disease. So, these are the three vasculitides that can cause non-traumatic splenic rupture. In case of inflammation, obviously autoimmune disorders very rarely cause neutrophilic inflammation. Uh, then we have bleeding diathesis. So bleeding diathesis, antiphospholipid antibody syndrome, when it causes a lupus anticoagulant hypoprothrombinemia syndrome. That is, there's an antibody against prothrombin which prevents its activity and therefore paradoxically causes bleeding. You can end up having a bleeding into the spleen, that kind of a rupture. Finally, much more commonly, you get this in disseminated intravascular coagulation. Okay. Then we have infectious inflammatory disorders. Like I said, any infection can cause enlargement of the spleen, but again, malaria, cotton malaria, visceral leishmaniasis, infectious mononucleosis, and Q fever are the four causes that cause very rapid increase in splenic size, and therefore the spleen can outstrip its blood supply and cause secondary late infarction. So, of this, infectious mononucleosis is the most anecdotally most quoted to cause the same. Then we have vasculitis. There is secondary vasculitis in infection. Obviously, I'm talking about infective endocarditis. And then we have inflammation, that is naturally a splenic abscess, which in we'll be discussing in detail in the next screencast. Then in case of splenic abscess, we need to also give due consideration to the possibility of mycobacterial nocardia actinomycosis, brucellosis, and typhoid related abscess formation, particularly in specific clinical scenarios, which we will discuss in that screencast. Finally, again, sepsis-related disseminated intravascular coagulation can also cause non-traumatic spleen rupture. Then we have neoplastic processes. See, essentially, any splenic mass can cause increase in splenic size, but the more malignant the mass is, the more likely it is to rupture. So this is particularly the case with splenic metastasis to the spleen due to a primary somewhere else. The enlargement See, of the splenic tissue due to say extramedullary hematopoiesis in proliferative neoplasms and in mature B cell neoplasms also can predispose to uh, you know infarction in those areas of the spleen. Then in case of tumors, a pancreatic mass that is locally invasive can involve the splenic artery and cause vessel damage. Finally, there can be primary degeneration of a metastasis to the spleen. So that is again a type of metastasis related non-traumatic spleen rupture. And finally, again, you can have malignancy related disseminated intravascular coagulation again. Okay, so as of now, based on the analysis of the history that was available at the beginning of this screencast, uh, there are two important things. There is sudden worsening of abdominal pain 2 days back with an increase of pain on taking a deep breath. So naturally, this is likely to be due to a splenic, uh, uh, you know, diffuse splenic enlargement or splenic rupture. Uh, okay. Now, the thing is that it's just a mildly enlarged spleen. It's not significantly enlarged. So it's probably not a spleen that is so large that it has outgrown its, blood supply. However, I would obviously require imaging to confirm all of this. Uh, that will be the discussion. That will be the point of discussion in the next screencast. And you'll have to, hold your horses till then. Okay, coming to the second part of this discussion, that is evaluation of diffuse renal inflammation. Now, acute interstitial nephritis has already been discussed under your approach to peripheral edema, part 5. So, I'm not going to go into any detail on that here because it's been discussed in detail there. And we'll be talking about pyelonephritis with or without renal abscess in detail. Now, in terms of acute interstitial nephritis, we discussed there are two broad mechanisms that can result in interstitial nephritis. One is direct tubular obstruction, and the second mechanism is infiltration of a inflammatory response against the tubule per se. So that secondarily causes desquamation of epithelial cells of the tubules into the lumen and causes obstruction. And we discussed that acute interstitial nephritis is what causes acute kidney injury with bilateral flank pain, and this is due to distension of the renal capsule. When it is chronic, this is not the presentation that the patients come with. They are actually present with tubular dysfunction resulting in various types of renal tubular acidosis and nephrogenic DI, with or without nephrogenic DI, and subnephrotic range proteinuria. Again, I've discussed it in detail there. Uh, okay, so I'm not going to go into the details again here. Uh, okay, now these were the causes of acute interstitial nephritis that I had discussed there. And again, I'm not going to go into details there, but these are the causes of acute interstitial nephritis. Okay. Now coming to pyelonephritis. So pyelonephritis by definition is a type of urinary tract infection. So that raises the question, what is a urinary tract infection? So a urinary tract infection clinically is defined as a clinically symptomatic patient who also has a positive urine culture. These symptoms can include fever and or altered mental status. They can include lower urinary tract symptoms that would include increased frequency of urination, urgency in urination, burning sensation or pain during micturition. They can also include abdominal pain due to flank pain with flank pain, which is obviously suspected to arise from the kidney. Obviously, suspected means it has to be confirmed by imaging, at least an ultrasonography. Okay, so this is the general heading, and pyelonephritis is only part of the big spectrum of urinary tract infections. It's not possible to discuss it in isolation, so I'm going to discuss the entire thing here. Okay. Now, importantly, a positive urine culture in this case would be defined as a culture that is positive for a single organism, and there are specific gender dependent cutoffs that are used, although these are not validated per se. For females, they are more than 1,000 colony forming units, and for males, it is more than 1 lakh colony forming units. Now, here, see, culture positivity per se is not significant. Clinical symptomatology is very important. However, one needs to understand that not all patients with a urinary tract infection are going to be able to tell you about the symptoms that they have. Say they have altered mental status, uh, they are not unlikely to be able to provide the history. In that situation, you often have to make a clinical judgment. Okay. Now, WBCs are present in urine in almost every case of urinary tract infection. But again, as we've discussed previously in our approach to peripheral edema, the WB pyuria or presence of WBCs in urine needs to be evaluated as its own differential diagnosis. Okay, RBCs are additionally present in about 1/3 of cases. Uh, so again, just because there is WBCs in urine and there is urine culture positivity, that does not constitute urinary tract infection. A urinary tract infection should be clinically symptomatic. The symptoms are a spectrum of symptoms, and these are the symptoms that can be attributed to it. Now, importantly, the less specific it is to the urinary tract, the more clinically expedient it is for you to rule out other possible causes of this that might contribute to this kind of symptomatology. For example, in an older lady, urinary tract symptoms may be related to problems in the anatomy of the pelvic floor. Similarly, abdominal pain with flank pain in this our case, our patient is likely splenic aneurysm. Okay, so if you find some WBCs in urine, that doesn't directly indicate that the patient has a UTI. Similarly, fever could have many causes, so it has to be evaluated as its own symptom, and obviously that is the entire point of this channel. Now, again, another important thing is that pyuria in isolation can also happen when you have urinary stasis and in relatively advanced cases of CKD or chronic kidney disease. Now, there's an important distinction that needs to be made regarding asymptomatic bacteria vis-a-vis urinary tract infection. The distinction essentially being that asymptomatic bacteria is just represents a culture positivity. Okay, so abbreviated as ASB and UTI. Both cases have culture positivity. Asymptomatic bacteria naturally doesn't have clinical features, whereas UTI does. Asymptomatic bacteria almost never requires treatment. There are two exceptions to this general rule. One is pregnancy, because asymptomatic bacteria in pregnancy is associated with risk of pyelonephritis, that is an ascending infection, and increased risk of fetal premature delivery, and therefore also actually independently associated with low birth weight. Urinary tract procedures that are likely to cause mucosal damage and therefore allows bacteria to enter into the bloodstream causing bacteremia are the second reason for giving antibiotic therapy. Now, urinary tract infections always require treatment. Okay, so once it's clinically symptomatic and that is attributable to a urinary infection, has to be treated. Now, the presence of asymptomatic bacteria in a catheterized patient is again not in itself a indication for treatment. Okay, the patient still has to be symptomatic. Okay, and long-standing indwelling catheters often, result in the presence of WBCs in the urine. So again, the patient has to be symptomatic, and often in such cases, removal of the catheter and replacement of a new catheter may be indicated, with obviously due consideration made for is the catheterization required even now. But otherwise, it's not in itself a require an indication for antibiotic therapy. Now, asymptomatic bacteria is very common, and it occurs in females between the ages of 20 to 40% in about 5% of cases, and overall in all elderly it occurs in up to 40 to 50% of cases. So especially in the elderly, where history can be a little difficult to elicit, often this becomes a clinical conundrum, and it can be a source of disputes between various specialties in infectious disease particularly. But again, people just need to discuss the situation clearly with each other, and usually we're able to come up with reasonable consensus. Okay, now there are two situations in which base symptomatic bacteria need not always be treated but may warrant treatment in specific situations. One is in post transplant cases, post-renal transplant, and patients who are significantly neutropenic. Again, because the mucosal defenses in these two cases are not as effective, or theoretically not as effective. So in that situation, there is an increased risk of bacteremia, at least theoretically speaking. But the data on this is not definitive. So in such situations, it depends on the clinical context also. And since I am not discussing the therapeutic reasoning here behind treatment of urinary tract infections, I'm not going to go into that. That's beyond the scope of this video. Finally, we have urinary tract infections, a subclassification. So, epidemiologically defined subtypes of urinary tract infection determine the likely underlying causative organism, and thus they dictate the empiric therapy. Now, the thing is that because cultures usually take 48 hours to come, often the patient needs to be treated prior to that. So, that depends on what bucket we can epidemiological subset of patients the patient can be clubbed into. So these subsets include uncomplicated UTI, the definition of which is pretty simple. It's a urinary tract infection restricted to the urinary bladder in a male or a female without urinary catheterization. Now, the thing is, there is some confusion between this, because in this situation, because in non-pregnant patients, females, pyelonephritis has very similar distribution of, like, the organisms causing it are very similar to uncomplicated UTI. So at times, uncomplicated UTI is extended to include that, and that group of patients also. But it's better to stick to this definition because of the data and the treatment that has been done. So it's easier to then extrapolate treatment, yeah, inferences on treatment based on the data that is available when you use this kind of a definition. Okay, but there is merit to the other argument also. Then there's complicated UTI. All other cases of UTI are complicated UTI. There is recurrent UTI, which is more than or equal to two UTIs occurring occurring more than two or equal to 14 days apart. This is not by definition, therefore, a complicated UTI. Just because it's recurrent, it is not complicated. Okay, complicated means that it is not a urinary tract infection restricted to the urinary bladder in a male or female without who's not been urinary has not undergone catheterization. Now, COT is catheter associated UTI. So UTI in a male or female who has intermittent or permanent urinary catheterization. So this includes intermittent catheterization also. Although if the patient's catheter has already been removed, often the only treatment that is required is the removal of the catheter. So in that situation, the patient may not require treatment. Then we have prostatitis. This is an infection of the prostate in a male or a transgender female, and this can be due to an extension of cystitis, that is inflammation of the mucosa of the urinary bladder, or due to hematogenous spread into the to involve the prostate. Okay, now there's an important caveat here. Urethritis is most commonly caused by a different set of organisms, not urinary tract infections. Urinary tract infection causing organisms, and therefore is better clubbed under the clinical epidemiological category of sexually transmitted infections. Uh, and this is technically not a UTI. So I'm not going to be discussing that here. And isolated urethral discomfort and or discharge is not enough to constitute symptoms of UTI. So we discussed lower urinary tract symptoms are compatible with the diagnosis of UTI, but isolated urethral discomfort is not. Okay. Okay. Now let's and try to understand what exactly happens. Why do people get urinary tract infections and how does that become pyelonephritis? Okay. So we have some pathomechanisms that cause UTI. So there are two possible factors that result in a infection of the urinary tract. Essentially, the urinary tract is can be conceptualized as a continuous column of fluid extending from the pelvic caliche, or rather the kidneys and the pelvic caliche system, right up till the bladder. Okay, and the outflow of the bladder on both sides. So that is one continuous anatomic structure, and there is urinary flow. So the flow itself is protective. So either if one of two things happens, that is there is abnormal introduction of non-commensal organisms into the urinary tract, or there is impairment of the local immunity in the mucosa of the urinary tract, you can end up developing an infection there. So this can happen due to anatomic and or functional abnormalities of the urinary tract, causing either reflux of urine from the bladder into the ureters, or stasis. Such situations arise due to either congenital disorders, in which it is called congenital abnormalities of kidney and urinary tract, abbreviated as CACUT, and it can happen with acquired disorders. And acquired disorders can fall under the category of pelvic floor prolapse, particularly in female patients, benign prostatic hyperplasia, to a lesser extent malignancy, because that would cause other symptoms also. Post-inflammatory situations, inflammation of the urinary tract has been compared in the previous discussion, so I'm not going to go into that. Again, the cause of inflammation and the possibility also depends on the location, and it can be due to neurogenic dysfunction of the bladder. Most commonly, this happens with diabetes and with chronic myelopathy, but it can happen with other neurological disorders as well, which we'll be discussing separately in our approach to bladder dysfunction. Now, the second thing that might mechanism by which this might happen is you may have impairment of local mucosal immunity in a patient who is postmenopausal. The reason for this is basically that low estrogen levels in postmenopausal ladies result in the atrophy of the vaginal mucosa, and that secondarily causes a replacement of the normal commensal lactobacilli within the vaginal flora with gram-negative bacteria. So now topical estrogen therapy does reduce the risk, therefore, of recurrent UTI in such patients. But obviously, systemic hormonal therapy has its own risk factors, and that is not something that can be prescribed. Second is diabetes mellitus. Now, the important thing is diabetes is actually one of the most common risk factors, and female patients with diabetes, as compared to female patients without diabetes, have higher rates of both asymptomatic bacteriuria as well as urinary tract infection. And these have been quoted to be up to 2 to 3 times that of the latter group. Then we have recurrent UTI. So recurrent UTI, as in there has been a previous infection, as I just described previously. So mean reinfection rates are around 2.6 per year after one UTI, and the range is around 0.3 to 7.6 per year. So I remember these three causes as MDR. So rather than thinking of multi-drug resistance, first think of MDR, that is menopause, diabetes, and recurrent UTI before you think of complicated things. Okay. Then we have genetic predisposition. So some patients actually genuinely have an increased genetic predisposition for UTI, and this is particularly due to lack of expression of certain blood group antigens. Now, specifically, this refers to the lack of expression of the quote unquote P blood group antigen. Now, this antigen basically contains a D-galactose residue. So two D-galactoses attached to each other. The P. fimbriae of uropathogenic gram-negative bacteria basically bind to this D-galactose, uh, and therefore increase the risk of UTI in patients who have this kind of a so are unable to, so that increases the risk of infection due to gram-negative bacteria. Again, impairment in innate immune responses to local infection, particularly interleukin 8 receptor and some TLR genes. This would be TLR 1, 2, 2, 6, and TLR 4 and 5. Why we'll discuss in clinical immunology parts, not right now. Okay, so these are the risk factors that have been described. Finally, there are some patient behavioral related factors that increase risk of both of these problems. So, and there are some physician behavior problems. That is, there are some iatrogenic causes that can result in this. So, in female patients, this includes the acquisition of a new sexual partner. In male patients, this basically includes penetrative anal intercourse. Okay, naturally, when male, in homosexual male intercourse, and this is particularly true if the person is uncircumcised rather, and so these are the two at risk populations that one must be careful about. Then we have iatrogenic, that is physician initiated. So that is the placement of a nephrostomy tube, especially whether or not it was indicated initially, and intermittent or permanent urinary catheterization. So in these two situations, one must always be sure that the procedure has been done with clear definite indication. In case of impairment of local mucosal immunity, patient behavior related is the usage of spermicide as a contraceptive agent. Uh, a specific component of spermicide, that is nanoxynol 9, is what is responsible because it is toxic to the normal vaginal commensal lactobacilli. And again, just like we saw with postmenopausal disease, it eventually results in replacement of these lactobacilli by gram-negative bacteria, increasing the risk of infection by these organisms. Then the second is the usage of diaphragm. Uh, then we have unnecessary or necessary antibiotic therapy, and therefore antibiotic therapy, urinary catheterization, and draining nephrostomy tube placement should be done only when indicated, and even when done as when indicated, there is a possibility of urinary tract infection. Finally, we have diabetes, and insulin therapy is independently associated with increased risk of urinary tract infection as compared to oral hypoglycemic agent use. Now, of that, there is a FDA warning against the use of SGLT2 inhibitors, theoretically because of the glycosuria they cause. Uh, but again, that does include, in some data does result in increased urinary tract infections, but it's not as cut and dry as that. So I'll leave it at that. It has been associated, but of the two, insulin therapy as compared to OHS is much more has a higher relative risk as compared to SGLT2 inhibitors. Now, after we consolidate all of the things that we've just discussed, we end up with a general epidemiology of urinary tract infections, and in individual cases, not particularly important, but there are certain trends that arise. So the first thing is that the lifetime risk of urinary tract infection is much higher in females. So that is around 80%. So 4 out of 5 ladies are likely to develop urinary tract infections, whereas in males it is much lower. It's only 14%. And again, in a male, urinary tract infection is almost always in the context of an anatomical abnormality or urinary catheterization. Okay, so that might require urological evaluation. Now, therefore, as you follow patients at different ages, at less than 1 year of age, UTIs are more common in males because they are more likely to have abnormalities of the kidney and urinary tract that are congenital. Between 1 and 50 years of age, it becomes the opposite. That is, females are much more likely to have urinary tract infections, particularly sexually active women. Finally, in elderly, it essentially equalizes, although initially at least women have a slight higher prediction. Now, coming to the next thing, that is your UTI relapse versus recurrence. So, as we discussed, recurrence is the presence of more than or equal to 2 episodes of UTI occurring. Okay, so now coming to relapse versus recurrence. So, as we discussed, recurrent UTI is more than equal to 2 episodes of UTI occurring more than equal to 2 weeks apart. Relapse is 2 episodes occurring within 2 weeks. Now, in case of early recurrence, we need to consider the possibility of drug resistance in CARC patient, and we need to consider the possibility of functional and anatomical abnormalities of the urinary tract. Now, in case of recurrent UTI, we need to consider risk factors for recurrence, and only if the risk factors for recurrence are not present do we go ahead with further evaluation. So, what are the risk factors for recurrence? They can be again divided into patient behavior related and other causes. Uh, so patient behavior related is again the a new recent new sexual partner in female patients, usage of spermicide and high frequency of sexual intercourse. Actually, this is a dose related thing. So the higher the frequency, the higher the risk. Then maternal history of UTI and UTI at the first UTI developing at an age younger than 15 years. Both of these likely to at least to some extent represent a genetic predisposition to urinary tract infection in ladies. Now, basically, recurrent UTI almost always will, warrant either culture, okay, to assess the possibility of drug resistance, and the second thing that may be warranted is you may require evaluation for abnormalities of the structure of the this thing of the evaluation for rather sexually transmitted infections, okay, including a pelvic exam. Now, again, whether or not it is complicated or uncomplicated, that determines the positive causative organism. So in case of uncomplicated and complicated, the most common organism is always E. coli, but it is almost exclusively E. coli in case of uncomplicated UTI. In case of complicated UTI, there are other organisms become relatively more likely. So these, in case of uncomplicated UTI, the second most common by far is Staph saprophyticus in 5 to 15% of cases. Everything else, that is Klebsiella, Proteus, Enterobacter, and Citrobacter, are a far distant second. Okay, less than 1% of cases. Whereas in cases of complicated UTI, Klebsiella, Proteus, and Citrobacter are significantly more likely, and you can even get Acinetobacter infection, Morganella infection, and even with infection with gram-positive cocci like Staph aureus and Enterococci. Now, and in summary, the diagnostic workup in cases of UTI depends on the syndrome that you are faced with. So, if you have an uncomplicated UTI, in cases of prior sexually transmitted infection, you need to perform a pelvic exam in addition to culture. So, in every case you have to do culture, a urinary culture. There's no doubt in that. That is, if the patient has symptoms attributable to a urinary tract infection, you do a proper urinary culture, and the details of which are how to perform a urinary culture is very important, and I would suggest you look it up. In case of complicated UTI, in every case we need evaluation for modified risk factors, that is anatomical or functional risk factors, but what extent you go to in order to identify these risk factors depends on the clinical situation. That is, it would you just ask history, would you just do a physical examination, would you go for imaging? Now, if you have a febrile male patient, you and maybe in cases of urinary stasis, gross hematuria, and recurrent UTI, there is a reasonable, reason to perform urological evaluation, which basically means a CT scan or a U ultrasound. Now, of this CT, will, as we'll discuss in the next screencast, should ideally be contrast enhanced, and there are certain phases that need to be taken into account. Now, in a patient with fever, altered mental status, leukocytosis, that is an elevation in TLC, or clinical features suggest to a pyelonephritis, that is flank pain specifically, blood cultures have to be sent because these patients definitely are at increased greatest probability of having bacteremia and sepsis because of that. So in case of COTI, if the patient has, that is catheter associated or UTI, if the patient has fever, again blood cultures have to be sent. So see, every case of UTI does not warrant the blood culture, but again a patient with fever, altered mental status, elevated TLC but significantly elevated, uh, and or clinical features such as pyelonephritis, as well as a catheterized patient who is febrile, you must send a blood culture because these patients are at increased risk of bacteremia. Finally, with prostatitis, all cases require urological evaluation. Usually, this is in the form of an ultrasound first, and then maybe a prostatic MRI, not an CT scan. That is outside of the scope of the present discussion. Maybe when we talk about an approach to lower urinary tract symptoms, we'll be discussing that. And in case of recurrent lower urinary tract infection symptoms, you can suspect chronic prostatitis. In case of chronic prostatitis, particularly, you must insist on a urological evaluation, particularly bladder outflow. Now, just to reiterate, all UTI almost always warrants a urinary culture. Okay, so there is no urine routine and urinary culture. There is essentially no situation in which you would not send for a urine culture. And I'm talking about an aerobic culture, naturally. So, and the second thing is that recurrent UTI in itself does not warrant further workup unless you are not don't have any clear reason why the patient has a recurrent UTI or the patient is likely to have a urological abnormality. Say it's a male patient, so things like that. Okay. Now, just a word on culture. Culture has to be a single organism. That is, a mixed growth is not considered positive. It may be considered positive in in three situations. One is chronic urinary retention, long-term urinary tract catheterization, and there is rectovesical fistulization. Of these, rectovesical fistulization definitely it should be considered positive, but the other two, a little bit of clinical judgment has to be taken into account. But these are MCQ questions, so I remember them as clear indications for considering a mixed culture as positive. Okay. Now, sometimes we do adjunctive tests in cases of UTI. So that can include a leukocyte esterase test and it can include a urine nitrate testing. These are usually available in normal urine routines. The principle of the leukocyte esterase test is basically that enzymes produced by intact or live neutrophils are likely to be present if there is acute neutrophil mediated inflammation against a bacterial pathogen causing UTI. And the other thing is urine nitrate testing. Nitrate testing basically implies that Enterobacteriaceae convert nitrates to nitrates, and therefore nitrates are no longer present in urine. The clinical application is if both are negative, there is a high negative predictive value for urinary tract infections. But again, I don't necessarily depend on this. Okay, the most important thing is clinical features, urinary culture, and risk factors, if any. False negative cases can happen in case of urine nitrate testing in cases of pregnancy, so it's not useful in pregnancy at all. And in case of diluted urine, particularly when the patient has polyuria, and often patients with urinary tract symptoms, particularly women, tend to increase their urine fluid intake. Okay, now although I normally don't talk about treatment in on this channel, I have to talk about treatment when it comes to infectious diseases because often response to treatment is itself a diagnostic clue. Okay, so breaking with tradition, I'll talk about treatment of UTI. The drug of choice for cystitis includes five equally efficacious options. Now, see, this has to be taken with a pinch of salt because it depends on the local resistance patterns of the organisms. So, in different areas of the world, it varies. And again, the literature on treatment of UTI is skewed in the favor of relatively less severe UTIs, and therefore we have a lot more data regarding treatment of cystitis as compared to pyelonephritis or male UTI. Okay, so again, the gravity or the weight of the suggestions that I make here has to be taken with a pinch of salt. And again, I don't mean this for this to be advice on the treatment of individual patients. Okay. Now, there are five options. One is fosfomycin. In case of female patients, we give 3 gram per oral stat. In case of males, we repeat it for 3 days. Uh, we can give oral fluoroquinolones. IV fluoroquinolones are almost never indicated because fluoroquinolones have up to 95% or higher oral bioavailability, regardless. Then we have for cystitis, Ceftran, that is trimethoprim sulfamethoxazole, one double strength tablet for 3 days. Then we have nitrofurantoin and piv mesili. Okay, and we have nitrofurantoin and piv miseli miscellaneum. I find it difficult to pronounce the word. Okay, so regardless, in pyelonephritis we have ceftriaxone. We give 1 gram IV once daily for 3 to 5 days. But this is ideally combined with TMP SMX. Then we have extended spectrum cephalosporins and carbapenems or aminoglycosides. Then, in case of male UTI, because of better penetration into the parenchyma of the urinary tract, TMP-SMX is preferred. Now, fluoroquinolones again have very good penetration, so fluoroquinolones are preferred, but the duration of treatment is 7 to 14 days. So, see, since I'm not an ID specialist, there are a lot of other considerations that have to be talked about, the bioavailability of oral agents, the tissue penetration the of individual agents, whether or not that tissue penetration is relevant in a clinical scenario, uh, drug resistance pattern in the local vicinity. Those are outside of the scope of this discussion, so I'm not going to go into that, and I'm not actually the right person to talk about it. So however, importantly, when assessing whether or not the patient has UTI, the if a patient has received fluoroquinolones, and it's likely that they should have responded to it, the absence of response should make you reconsider the possibility of a urinary tract infection. Okay. And two specific scenarios, we have slightly different treatment advice. One is recurrent pyelonephritis or recent urinary tract manipulation. So in that situation, the apt treatment is A for ampicillin plus sulbactam, P for piperacillin tazobactam, and T for your ticarcillin with clavulanic acid. Finally, in case of prostatitis, it warrants slightly more prolonged, not slightly, significantly more prolonged therapy. So, in case of acute prostatitis, the true duration of treatment is often 2 to 4 weeks, and for chronic prostatitis, the treatment can be 4 to 6 weeks. And in case of recurrent prostatitis, that can be extended up to 3 months. Okay. Now coming to the last part of our discussion, that is evaluation of splenic or renal in arterial infarction. So again, any infarction can be due to thrombosis, in situ thrombosis of the vessel. So you have a vessel, a thrombus forms inside the vessel. You can have embolization of a embolus into the vessel from somewhere proximal to the vessel, or you can have inflammation of the vessel, so vessel wall damage, particularly vasculitis. Now, embolization can be from a artery proximal, a larger artery proximal to the vessel that has gotten embolized. So there's a plaque, say here, embolus goes from proximal artery into a distal vessel, or it can be due to an embolus arising within the heart. So that is called a cardioembolic phenomenon. Vasculitis can itself be primary or it could be secondary. And among secondary vasculitides, infective endocarditis and bacteremia are two very important causes. Now, thrombosis and artery to artery embolism is almost always related to atherosclerosis, and obviously, therefore, patients with higher risk of atherosclerosis are more likely to develop these problems. Arterial thrombosis can importantly also occur in antiphospholipid antibody syndrome and paroxysmal nocturnal hemoglobinuria, although this is not routinely the most common cause. So this is not something that you need to evaluate under all circumstances, but often in my situation as a clinical immunologist, you end up having to evaluate this quite frequently. Okay. Uh, Now, in case of the renal arteries, all of these mechanisms are possible causes of renal artery infarction. Whereas in case of splenic arteries, as we've discussed, the splenic arteries are very long and therefore they have a lot of pressure head loss. That is, the pressure lost due to friction of the blood flow against the blood vessel wall results in the flow becoming much more and more laminar as you go more and more towards the spleen. So, as a result, the splenic artery very rarely is affected by atherosclerosis and therefore is very unlikely to have thrombosis or artery to artery embolization. Okay. Uh, Again, and clinically also, it's very unlikely to be painful. So it's not really a cause of non-traumatic splenic rupture. So that essentially brings us to the end of this discussion. In this screencast, I have discussed the following things. I've enumerated the causes of abdominal pain due to splenic enlargement, talked about diffuse splenic inflammation versus infiltration, and defined what are the causes of non-traumatic splenic rupture. I have enumerated the causes of diffuse splenic inflammation, touched upon acute interstitial nephritis. I would urge you to go and have a look at the specialized discussion on that is already there on the channel. Um, Pyelonephritis was discussed. Renal abscess was not discussed. It will be discussed in in the next discussion screencast. We described pyelonephritis and defined it as a form of urinary tract infection, and therefore what constitutes a urinary tract infection. We differentiated asymptomatic bacteriuria from urinary tract infection. We described the spectrum of clinical entities that also constitute UTI in addition to pyelonephritis. We understood the pathomechanisms that result in the development of urinary tract infection and the resultant epidemiology and risk factors that have to be considered in patients with UTI. We talked about treatment protocols in UTI, although very superficially, and including in special scenarios. Again, I want to highlight how that is relevant diagnostically. Okay. Uh, Enumerated the causes of splenic and renal artery infarction and decided that thrombosis, embolization, and vasculitis are all likely causes of renal artery infarction, but splenic artery infarction is much less likely to be due to thrombosis, and we explained why. So that brings us to the end of the discussion. Thank you for watching, and I'll see you next time.